Good evening. Welcome to the Prostate Cancer Roundtable talk today. So my name is Richard Zhang. I'm a general medical oncologist and hematologist with special interest in GU tumor, including prostate cancer. So I'm very pleased to be here today and then have 5 of my partners to have this roundtable discussion. So why don't we just have a one-by-one introduction today?
Okay, I'm Dr. Michael Epstein. I'm medical oncologist in Fort Wayne, Indiana, and practicing for almost 25 years, doing all kinds of hematology oncology, including GU oncology, with the prostate cancer, bladder cancer, kidney cancer, etc.
Okay.
Hi there. My name is Dr. Sadiq. I'm also one of the general medical oncologists here with Fort Wayne Medical Oncology. Been in practice for almost 13 years, and my subspecialty is a little bit more thoracic and GI, but I also see GU oncology.
Great. Dr. Babu?
Yeah. Sunil Babu, one of the general hematologist oncologists with a special interest in clinical research for the group. Again, just like my colleagues, I see all histologies as well as hematology. Glad to be here.
I'm Ryan Gonzales. I'm also part of Fort Wayne Oncology and Hematology. I've been practicing for about 15 years. Pretty much my practice mostly consists of thoracic as well as GI, and I also have GU, so I pretty much do everything.
I'm David Zimmerman. I've been in practice for 23 years. I do a lot of hematologic malignancies and a lot of prostate cancer and other GU cancers.
Great. So apparently all of us are a community-based practice, so none of us are dedicated GU medical oncologists. But I think it's important to let the audience know our experience to treat prostate cancer in the community practice setting. So I do have some guideline today, so I think I will try my best to help to cover a lot of topics. So let's start with castration-sensitive prostate cancer. I think that's probably accounts for a lot of our first encounter of our prostate cancer patient. So some definition of castration-sensitive prostate cancer, meaning the patient still is castration-sensitive. They never have been exposed to androgen deprivation therapy. The issues right now is we have so many new testing, the genetic testing tools, the molecular testing tools, and also imaging tools coming out these days. So I guess my first question is, in your practice, when you see a patient you believe is a castration-sensitive prostate cancer patient, what type of tests do you do? So imaging-wise, and then molecular testing-wise, or genetic testing-wise?
Yeah, I mean, I think things have evolved, especially in the last couple of years. Mm-hmm. With PSMA PET becoming available in our community.
Oh yeah.
So, in general, assuming the patient has kind of low volume disease from whatever testing that has already happened, I try to get a baseline PSMA PET if I can get it.
Yes.
Just to define, because generally you end up seeing a little more disease than whatever modality was used prior to that. Then, obviously getting that baseline PSA test. And what was your other question?
Other genetic testing, molecular testing,
yes.
do you do that test, or when do you do the
I'm trying to
testing?
do it earlier, genetic testing.
I'm doing upfront.
Upfront?
Upfront.
And if it is bone-only disease, sometimes, you don't have the biopsy. Or, if the prostate biopsy was done years ago, sometimes, can do a liquid biopsy at the time of this metastatic disease diagnosis.
So in my practice, sometimes I had some issues about getting these PSMA PET scans up front. Mm-hmm. So a couple of times insurance, it would be like, no, you have to get the CT scan and a bone scan first. And then if there's some questionable thing or you don't get the right clinical picture match with the scans, then you can get your PSMA. So sometimes you do get into a little bit of an issue in getting those PSMA PET scans up front.
Yeah.
And then for the molecular testing, I do check, as Dr. Zimmerman said, up front. I'll get my BRCA testing done and the P10s and all those. I'll do them up front.
I do a little bit different because landscape in the prostate cancer changed. It used to be straightforward, very simple. Today we have a lot of treatment, and I think we see more people in the early stage just because urologists don't feel comfortable treating patients anymore like they used to do. They just put on hormonal deprivation and they knew not too many options after that. So we see more and more patients, castration-sensitive patients, at really early stage because they know oncologists can do more. So when I see patients and patients is a low risk, I don't do PSMA test. I don't. Do I do genetics on everybody? No. Not
everybody.
No, not at all. If patient is old, so I don't do it. If patient has an early stage, and I know I can manage it for hormonal approach for a long time, I just simply monitor PSA. And usually they already come with the imaging test. If none, I still just do bone scan if I have concern for bone disease.
That's good. So I think you brought up a very good topic to discuss is what's the difference between the high sensitivity PSMA scan and traditional CT scan and bone scan? I think that's a very important thing. Based on my understanding, most the practice-changing landmark published trials are based on traditional imaging, CT and bone scan. In our real-world practice, we rely on PSMA scans so much. How to translate the published trial data to our daily real-world practice, I think that's the question. So do you guys feel the same way? Sometimes say the traditional imaging shows nothing or very low volume disease, but if you order a PSMA PET scan, you're like, should I call this a high volume disease because it shows multiple lesions, or you still treat it as like a low volume disease?
I think PSMA picks up a lot of more lymph nodes, it seems like, as far as lymphadenopathy, it says normal, and then, CT says normal, but then when you do the PSMA, it actually shows multiple uptake in lymph nodes.
Yes. Will that change your practice? So let's say previously you think this is a low volume disease, now with a PSMA you see more. Will you change your approach?
I've seen multiple cases of PSMA false positive. PSMA, it's extremely sensitive test. So if clinical picture doesn't get along with the PSMA test, I do biopsy. I did biopsy on the lung lesions, I did biopsy on the liver lesions, on the subclavial lymph node, and it turned out to be not malignant, although PSMA test was grossly positive.
Does that change your systemic treatment options for the patient?
Absolutely, yes.
I had a patient who had a low-grade lymphoma that lit up on a PSMA scan.
Wow.
I biopsied, yeah.
And then end up to be a lymphoma.
Yeah.
So you have to use basically your clinical judgment and PSMA, not rely on PSMA completely.
Gotcha. So that's actually true. So PSMA scan we know has a high specificity, high sensitivity. On the other hand, we do have some false positive. So have you ever run into false positivity of the PSMA scan?
I had a couple of times where I had to have the discussion with my radiologist. Rib lesion, very low activity in the rib, and that SUV was so low, but it was kind of positive above the liver levels. So that was a little bit of a difficult discussion with my radiologist, that is it a true positive, is it a false positive? My CT scans and bone scans were negative.
That's
So
very
that's
common.
something that I had to make a clinical decision, and we decided to call not a metastatic lesion. That's what
I think
it is.
that's
I think there is a higher false positive pickup in the ribs because of the injuries and all that.
Bones.
Bones, yes.
And it's in ganglion too, right? There's an increase in certain ganglion. It makes it look like a lymph
Salivary
node.
gland and then liver sometimes it shows.
And the other issue is, right now PSMA PETs have come into our market only in the last 18 months or so. The radiologists who are reading, they're also kind of getting used to it. And there are so many different isotopes in the market. And, I don't know, I mean, not being a radiologist, I don't know the complexities of how these different isotopes, do they need to be read slightly differently? Because the
that's a very good question.
SUV ratings could be different. So I hope our radiologists are, pretty
I
competent
talked with
in
some
doing
of them.
that.
I think that they are equally confused or undetermined.